we can get started. All right, so we're gonna talk about automation limitation today and knowing what the vent is and is not capable of doing. So a couple of disclosures: we do not endorse any mode, ventilator, or manufacturer, and whatever we say is our opinion does not represent the Cleveland Clinic's. These are some of our disclosures here on the slides. Moving on. This is a recorded session, so please keep your microphone muted. And if you want to comment, please use the chat function of WebEx.
Why don't you introduce yourself, Anika?
Yeah, that's it. For most of you online who don't know me, I'm Anika. I'm one of the pulmonary and critical care fellows at Cleveland Clinic and the SEVA fellow. All right. We'll go over the CRC and the credit at the end of the session. All right, so we can just get started. Over here, we are just going to go over some basics of ASV ventilation, which we commonly find on the Hamilton. So we'll just talk about some basics on this slide, and then we'll go into a specific waveform and troubleshooting a particular problem. Can you see my cursor, Rob?
Yes.
Okay. Okay. So basically, ASV uses a targeting scheme that we call OI, which is optimal and intelligent. Does anyone want to comment on what these two targeting schemes do? What does optimal do and what does intelligent do? And then Rob, you'll have to tell me if anything comes up in the chat.
Yeah, I'm looking.
Okay. If not, we can just talk about this. So optimal, so there's two targeting schemes. Optimal it comes from the Otis equation, which chooses or tries to choose the optimal rate and tidal volume to decrease the mechanical power of the ventilator. So it has certain rules that limit the tidal volume so that it won't go above a certain amount and result in ventilator-induced lung injury. And it tries to set your tidal volume and your rate to achieve a certain minute ventilation. If it's based on some rules to simulate what your brain would do if the patient was breathing spontaneously. This was mostly designed for normal lungs and did not actually factor in disease states like ARDS or obstructive lung disease. And here's where the intelligent part of the targeting scheme comes in, which is based on expert rules to keep the tidal volume as close to 6 cc's per kg as possible, to determine the rate based on the time constant, so not too high that will cause air trapping, but also not too low that it would cause hypoventilation. So it tries to set this rate and tidal volume based on a calculated minute ventilation, which is calculated based on the ideal body weight, the compliance, resistance, and assumed dead space. And this, what we're seeing here, is a standard screen that you see on most Hamilton ventilators when you're in adaptive support ventilation, where you have tidal volume here on the y-axis and rate here on the x-axis. And then this line gives us all of the combinations of tidal volume and rate that will achieve a minute ventilation of 8 liters per minute. So up here, a very high tidal volume with a low rate, and down here, a very high rate with a low tidal volume, all to achieve this calculated minute ventilation of 8 liters per minute. The green dot represents the target, so that's what the vent is trying to achieve with the patient. And then our little cross over here is where the patient actually is within this target. So over here, where you can see that the target as well as the cross overlay each other, that's suggestive of the fact that the vent is doing everything, and this is a completely passive patient. Because if the patient was breathing spontaneously, they were unlikely to be on this curve. And then the red box gives us the general area of safety that the vent is trying to keep the patient at. Rob, did I miss anything here?
No, that's good. You want to talk about the cross, the yellow cross?
Yeah. The yellow cross is where the patient is at like, so this is the green circle is the target, and the yellow cross is what the patient is currently doing. So that is 492 cc's with 16 breaths per minute. And when that generally overlays, what that means is that the patient is unlikely to be doing any spontaneous effort.
That's right. And so what we're looking at right now is all mandatory breaths.
Yes.
And if that cross was off of that line, it would be all spontaneous breaths and not restricted to the target rate, but pretty much restricted to the target tidal volume, although we'll see how that's affected in the next slide.
Yeah. Any questions about this?
Nope, nothing in the chat.
All righty. Okay, so now we'll go to our waveform. Get my pen here. Okay. So we did go over a little bit of the tag here with ASV, but why don't we do that one again? So what's the tag here? Are we getting any replies, Rob?
Nothing yet.
Nothing yet? All right. We'll just give that another couple seconds.
Well, we should say that you can't really tell what the whole tag is just by looking at this.
What is that?
You'd have to look up ASV on the ventilator mode map. But we can certainly discern what the control variable is, right?
Right, right. So we'll start there. Is this pressure control or volume control?
Ariel says it looks like PC.
All righty. And then is this CMV, CSV, or IMV?
Okay. Ariel has pointed out that he sees, and Sherry sees that this is IMV because we see both spontaneous and mandatory breaths.
Yeah, so we have breath 1 and 2 that are spontaneous, and then the subsequent ones are mandatory. So this is IMV. And then if we look up what the tag for ASV is this like what kind of IMV is this?
Sherry says IMV3.
Yeah, and it's not really possible to determine whether this is IMV2 or 3 just by looking at the waveform, but that's why we look at this part over here, and then we can see that this is an ASV setting where you're trying to support a certain percentage of the minute ventilation. So here we're trying to support 120%.
Right, so just to review, IMV3 means that spontaneous breaths can suppress the mandatory breaths like we see in the first two if the minute ventilation is above the target. And the target is calculated by the targeting scheme.
Right. And then we kind of talked about the targeting scheme, which is for both mandatory and spontaneous breaths. This is OI, OI. So this is PC-IMV3 OI, OI.
Very good.
Any questions about how we got there? Okay. All right, so now we'll go into the load. What is the load in inspiration and what's the load in expiration? Anyone wants to talk about the load in inspiration? Elastic, resistive, or PMUS?
So remember, if you're in a pressure control mode, you want to look at the flow and volume waveforms, right, to see the evidence of the load. Ariel says PMUS.
PMUS,
Anything
okay.
else?
All right, so if we number all of our breaths over here, so we have 2, 4,
Good.
5, 6, and 7. So if we number all of our breaths, these two we said are spontaneous, and we can kind of see that even with the flow waveform. Over here, we have one mandatory breath that does not appear to have much PMUS. So over here, we can see a nice exponential decline over here, and we come back to 0 in the flow waveform pretty fast. Is everyone kind of able to see that? All of our other waveforms are a little distorted by PMUS. All of our other mandatory ones are distorted by PMUS. So over here, we can see that it comes back to baseline pretty quickly. So in inspiration, yes, we have elastic, and then everywhere else we do see some PMUS. So we have PMUS as well. And then same thing for exhalation. So the flow waveform is always passive in exhalation. We can see that we come back to baseline for most of these pretty quickly. Is that evident?
Yep.
All right, so we'll call this elastic as well. And then Ariel, did you mean PMUS for inspiration and expiration, or just inspiration?
There are some PMASC on some of them, and there are another, I would say, not voluntary PMASC after, but there is some sort of, it seems to be PMASC or means inspiratory effort during expiration also.
Yeah, there's some PMUS over here. There's some PMUS that's evident here, maybe here. So some expiratory PMUS, like there's some PMUS noted in expiration, and we'll kind of talk about whether that's expiratory work or not. So we have PC-IMV3, OI, and we have an elastic load in inspiration and expiration, and then some PMUS, which is scattered all over, which we're going to talk about a little bit more. All right, coming to the meat of the screenshot. Are there any PV discordances? So we'll go in order. Are there any trigger discordances? Anything on either our spontaneous or mandatory breath? Sorry, Rob, what was that?
No, we're not seeing anything in the chat. People are a little reluctant.
That's okay.
Well, stuff's coming in now.
What are we seeing in the chat?
So Ariel points out that you can see that this is a flow trigger because you have those little purple triangles or magenta triangles.
Yes, and if this was a pressure trigger, we would see yellow triangles. Yes, absolutely.
And Sherry sees the failed trigger effort between 4 and 5.
Yes, this is our failed trigger effort over here. So this one is failed. It's harder to do than I thought.
And if you look at the last waveform is the CO2, the capnogram, and you see a little cleft in there. So between 5 and 6, it's hard to see on the flow waveform, but the CO2 waveform clearly shows there was a failed trigger effort there, right?
Yeah. So here, and then, so we have a failed trigger effort here, and then we can see that a little bit more amplified. There's a failed trigger effort over here as well. What about anything else? Any other trigger discordances that are being seen?
Sherry sees an early trigger.
All right. Yes. So this here, so breath 3, 5, 6, and 7, both on the flow waveform as well as the pressure waveform, we're able to see a deviation in the waveform. So a mandatory breath followed by evidence of patient effort pointing towards an early trigger. So if we were drawing the PMUS out, it didn't start before the breath here. It started somewhere around here, ended over here for this breath, somewhere here, and maybe ended here for this breath. And then we can see it starting over here as well. So yeah, most of our breaths have an early trigger. Anything else on trigger? Probably not. Moving on to inspiration. Are we calling this assistance, over assistance, or under assistance? Just for brevity's sake, we will call this in general assistance, but we did kind of talk about maybe there was some under assistance here because the patient is doing work on the vent, but it's not unacceptable. So we'll call this one assistance. What about our cycle? Anything wrong with our cycle? Normal, early, late?
Late cycle. Late cycle induced by early triggering?
Late cycle.
Early trigger. Let's back up a second. Sherry asks, can early trigger be a sign of over assistance?
Early trigger be a sign of over assistance? Kind of had this conversation yesterday. Do you want to take this one?
Well, it's complicated. I think early trigger is usually a manifestation of too much sedation, right?
Right.
And
right.
sometimes maybe a neurological response to the lungs expanding, so the ventilator triggers, and then the patient has some sort of neurological response to trigger. It's hard to say. I wouldn't say that this is necessarily over assistance.
Right.
But maybe you're thinking that the way to fix this is what we'll talk about in a minute. Ariel says late cycle. Well, it wouldn't be late cycle because the effort extends beyond the cycle time, right? So it would be early cycle as a result of early trigger.
Right. So if we look at the PMUS here, the PMUS extends till here, and the breath is being cycled off before the PMUS ends. So if anything, this would be early cycle, but then as we've talked about in previous vent rounds, we kind of go in order, and early trigger is likely to cause early cycle, and we'd still mostly only focus on the early trigger and try to fix that one first. Even here, if we draw out the PMUS ends somewhere here, but the breath has been cycled off before that. So this would be an early cycle.
Yep, that's the way I see it.
And then finally, in expiration, do we see any expiratory work? Probably not. We see some PMUS there, which is our early trigger, where the vent has started the breath, and then we see patient effort, but not necessarily this patient doing work against the vent or expiratory effort against the ventilator. We're probably going to call this normal.
Yeah.
Any questions here so far about our PV discordances? So we have our 2 spontaneous breaths, and then in almost all of our mandatory breaths, we're seeing early trigger and then 1 failed trigger. Any questions about that? Any part of that that's probably unclear? One of the additional things on top of seeing the deviations of the waveform is that we can see how different the tidal volumes are based on the presence of PMUS. So we have these 2 spontaneous breaths, and then over here we have our mandatory breath that had a certain tidal volume. Here there was probably a larger PMUS, and we can see that the volume is probably touching close to 800 cc's over there.
That's a good illustration of how P vent plus P mus gives you the tidal volume. They add together.
Yeah. Okay, so now that we've identified 2 unacceptable PVIs, and we're calling these high risk or unacceptable PVIs because of this large tidal volume, which is not controlled, sometimes leading to a double tidal volume, what would be the solution to this? Like, what would be one of our potential solutions to early trigger? And we'll just, Rob, let me know if anything comes up in the chat.
Ariel knows. He says it depends on the mode. Do you want to keep ASV? Well, that's the question, isn't it? Yeah.
Right. So it kind of, I guess, like we'll start with one step simpler than that too. It kind of depends on the goal. But let's say that our goal is comfort here. What would we want to do about it? Like, Ariel, why would you think that ASV is not a good mode? And we're going to talk about that for sure. So you're definitely right. But like, walk us through that thought process.
First, because I was in front of that patient when I got the image, and I'm sorry that I used a long time scale because I wanted to get more breath. But remember that on ASV, you set the target minute ventilation, and it's 120%.
What are you trying to change here that you're not able to change on ASV?
I would try, I mean, if in any mode, I would switch to pressure support. But ASV, since it's a form of IMV type 3, you can reduce the percentage of assistance to 120 and try to make it lower, and just to see if the patient is picking up more, and you remove the mandatory rate.
Okay, right. So the rate, exactly. So here, when we're talking about early trigger, one of the causes, or in general, early trigger is relatively a new phenomenon, but one of the thought processes behind the cause is an entrainment phenomenon where the mechanical breath and the mechanical rate and the patient's respiratory rate entrain because of higher levels of sedation and toxicity from sedative medication. So one of the things to try to do to help this is to decrease the mandatory rate. If your goal is comfort, to try to decrease the mandatory rate, to decouple the mechanical ventilator rate and the patient's respiratory rate. And in the hope that if you decouple that, or if you decrease the rate well enough to simulate some amount of CO2 buildup or acidosis, you'll trigger a spontaneous patient, sorry, not spontaneous, but the patient will start to trigger faster than your set rate. So one of the solutions here is to decrease the rate. And as we talked about in some of our basics of ASV in the previous slide, we don't actually set the rate here. So here the patient is breathing over the, breathing faster than whatever the vent is has set for the patient, because we have evidence of some spontaneous breath, but probably because we want to support 120% of the minute ventilation. That minute ventilation is not being met, and therefore the mandatory breaths are continuing despite some spontaneous effort. So what we'd want to do is decrease the rate. And since we don't have that control, over here, the only control we have is we can decrease the percentage of minute ventilation we want to support. So we can go down from 120 to 100 to 80, but it doesn't really give us control over whether you're going to decrease the tidal volume or the rate. And in general, ASV would not drop the rate to as low as maybe 10 or 12, which is sometimes what we do in clinical practice when we see early trigger. So in this case, exactly like what Ariel said, this ASV, even though it is adaptive, intelligent, optimal, has all these rules to protect the patient and minimize the need for someone to be there at bedside all the time. This may be one of the situations where you don't have the kind of control that you want with ASV, and maybe we'd have to switch to a slightly less intelligent mode, maybe like a regular PC-IMV-S, or like Ariel said, PC-CSV S, and see whether or not the patient starts to trigger. Rob, anything to add there?
Yeah, again, anything you do on the ventilator is guided by your goal, right? So if the goal was comfort, then as Ariel suggested, you might just go to pressure support and wait for the patient to start triggering the ventilator. Right. But if you are at marginal blood gases to begin with, and you wanted safety primarily, you might go to PC-IMV2, right? Yeah. Which means that if the patient, if you could drop the mandatory rate intentionally, and then hopefully the patient would pick up the spontaneous breaths. Now, you might say, well, how can you get PC-IMV2 out of a Hamilton ventilator?
Yeah.
Ariel knows the answer to this, right?
Yeah, go for it, Ariel.
Rob, I remember this image. What I wanted to prove in this image was that even the most intelligent mode is incapable of dealing with what we call early triggering or reverse triggering.
Right.
What I usually do, it's one of the ways that I try to do at bedside. Sometimes I make an expiratory pause to see if there is an inspiratory effort or not. If there is no inspiratory effort, there's no way you can decrease, switch to pressure support. But if there is any effort, I would try to measure the effort and try to figure out the respiratory rate to match that effort. And sometimes you can make it disappear. I mean, the reverse triggering.
Yep.
All right.
That's a fairly complicated way to do it, but you could, like I said, you could just put on this ventilator, it's called PC-IMV plus, and then you activate P-Sync, right? And with P-Sync, then this becomes IMV2. So now you have both your safety and your comfort, and you just wait for the patient to suppress the mandatory breaths with the spontaneous breaths.
Yeah, Rob, yes, but remember that the waiting time for another spontaneous breath is the total cycle time. So you need to decrease the rate below 10 and try to give a longer time to a spontaneous breath to appear.
And you can do that with the PC-SIMV plus mode, right?
With the P-Sync, yeah.
With
All right,
P-Sync, yeah.
we're gonna just summarize.
Time to wrap it up, yeah.
So the main things we talked about is what is the optimal and then what is the intelligent part of the targeting scheme. We talked a little bit about basics of ASV and what you can and cannot control on ASV. And then early triggers, what are potential solutions to early triggers? And then how do we approach that on an event where you cannot control the rate, but maybe changing it, maybe changing to something else on the Hamilton. That would be the way to troubleshoot early trigger if your goal is comfort. And that's that. Any questions?
Nothing in the chat. You want to show the last slide with the CME stuff?
Yes.
There you go.
So this is our event code and then CME QR codes for anyone who needs it. I'll just leave it on this slide. And then for anyone who wants to join our SEVA program, we have a summit coming up in September. You can just sign up online.
And thank you to Ariel for providing the graphic.
Thank you, Ariel.
Goodbye, everybody.